Imagine you take your car in, right, for a routine oil change. You're just sitting there in the waiting room, sipping some terrible coffee, and the mechanic comes out.
Yeah, wiping his hands on a rag, looking serious.
Exactly. And he says, your oil is totally fine, but while I was under there, I noticed this tiny, weird rattle in the undercarriage.
And you've literally never heard this rattle.
Never. It's not affecting how the car drives at all, but now that you know it's there, your brain just screams, tear apart the engine, fix it right now.
Right, because we hate the idea of a hidden problem.
We really do. But what if, like, an entire panel of automotive engineers told you that fixing that invisible rattle is actually the most dangerous thing you could possibly do to the car?
It's a great analogy.
Yeah.
Because that urge to intervene is just such a deeply ingrained human reflex, especially when we feel vulnerable.
Yeah.
We're totally conditioned to believe that finding something early is universally, unequivocally a good thing.
Right. Early detection saves lives. That's the mantra.
Exactly.
Yeah.
But when we transition from car mechanics to human biology specifically into the really complex landscape of postmenopausal health, that instinct can actually lead us into a pretty dangerous trap.
And that trap is exactly what we're focusing on for today's deep dive. We're looking at a massive stack of medical guidelines to answer one really specific question.
Which is how an ethical clinic screens for and prevents the overtreatment of normal postmenopausal tissue changes when a patient has, well, absolutely no symptoms.
Right. And for you listening, as someone who wants to be thoroughly well-informed without the overwhelming medical jargon, you are in the right place. We are pulling our context today from the clinical practice guidelines of the Society of Obstetricians and Gynecologists of Canada, the SOGC.
As well as the Royal College of Obstetricians and Gynecologists, the British Menopause Society, and a bunch of comprehensive NHS Trust guidelines.
Because the stakes here are incredibly high. We're trying to navigate this razor-thin line between genuinely catching a developing cancer early and, subjecting a perfectly healthy person to painful, unnecessary medical procedures.
Sometimes life-altering procedures, yeah.
So, let's unpack this. To even begin to understand this tension, we have to look at how these asymptomatic changes are discovered in the first place, right?
Right, because by definition, if a patient has no symptoms, no bleeding, no pain, they aren't exactly walking into a clinic asking a doctor to check their uterine lining.
No, of course not. So how are they finding this stuff?
Well, in modern medicine, we just order a staggering number of scans. So a woman might go in for a transvaginal ultrasound or a pelvic MRI for a completely unrelated issue.
Like what kind of issue?
Maybe her primary care doctor is investigating just a vague abdominal complaint, or perhaps she had a routine pelvic exam, but because of her anatomy, the physical exam just wasn't adequate to feel the structures around the uterus, the adnexy.
Okay, so the doctor just orders a scan to get a clear picture. Better safe than sorry.
Exactly. And then, out of nowhere, the radiologist's report comes back flagging what we call an incidental finding.
Right. They spot a thickened endometrium, which is the lining of the uterus, or maybe like a small ovarian cyst.
Yeah, going back to your car analogy, this is the mechanic finding the rattle while looking at the oil.
Right. But I have to push back on the premise here. Why on earth is finding a thickened uterine lining early considered a bad thing? I mean, if I get a report saying my tissue is unusually thick, I'm going to want a biopsy yesterday.
Well, I'm going to push back on your car analogy, actually.
Fair enough.
It works for capturing that surprise factor, but it completely breaks down when you consider the reality of the medical intervention. I mean, a mechanic taking apart an engine doesn't cause the engine to suffer crippling anxiety.
That's true.
And if a wrench slips, the engine doesn't bleed out. In humans, the intervention has a massive cost.
Yeah, okay, point taken.
Yeah, and what's fascinating here is that the major medical societies we're looking at today explicitly state that transvaginal ultrasounds should not be used to screen for endometrial cancer in asymptomatic women.
Wait, they explicitly say not to use it, but why?
Because of the raw incidence rate. The actual occurrence of endometrial cancer in a population of women who have gone through menopause and are not experiencing any bleeding is just vanishingly rare.
Okay, vanishingly rare sounds nice and comforting, but if I'm holding a lab report that says abnormal, I'm not thinking about population statistics, I'm thinking I'm the one exception.
Sure, which is human nature. So let's ground this in the actual data then. The SOGC guidelines cite this landmark piece of research known as the Archer study.
Okay, what did they do?
The researchers took 801 perimenopausal and postmenopausal women who had zero symptoms. None. They were just enrolling in a hormone replacement therapy trial, so they needed a baseline check.
Just a standard physical, basically.
Right. And the researchers performed an endometrial biopsy on every single one of them.
Wait, hold on. They took 800 healthy women who felt perfectly fine and put them through an invasive, painful uterine biopsy.
801, yeah, all of them. And out of those 801 biopsies, do you know how many cases of endometrial cancer they actually found?
I mean, if it's rare, maybe 50? 20?
Yeah.
Wait, seriously. One case out of 800 women.
Just one.
So that means 800 women went through the anxiety of waiting for cancer results and the physical trauma of the procedure for absolutely nothing.
For nothing. The tissue they extracted was mostly just normal benign biology doing what it does.
Yeah.
Nearly 47% of the tissue was atrophic.
Atrophic. What does that mean at a cellular level?
It just means the tissue is thin, inactive, and essentially sleeping because estrogen levels have naturally dropped. Another 16% was proliferative, meaning it was just in a normal benign growth phase.
So if the risk of cancer is that incredibly low, why is this even a debate? Like, why are so many non-bleeding women still being referred for these invasive biopsies when a scan shows a thick lining?
It's a great question.
Right, because if the math proves it's a terrible idea, what is driving a clinician to order the test anyway?
The answer lies in a very well-intentioned, but statistically disastrous medical habit: extrapolation.
Extrapolation, meaning they take a rule for one group and apply it to another.
Exactly. Doctors are terrified of missing a diagnosis, and they have very strict, well-established rules for a completely different group of patients, women, who do have postmenopausal bleeding.
Because bleeding after menopause is like the universal red flag.
It is the defining symptom. In women who present with postmenopausal bleeding, endometrial cancer is actually present in roughly 5 to 10% of those cases.
Oh, wow. That is a massive jump in probability.
Right. So for that specific high-risk population, the guidelines are very rigid. If a bleeding woman has an endometrial thickness of greater than 4 millimeters, though some guidelines allow up to 5 millimeters, it triggers an immediate biopsy.
Or a hysteroscopy, right, where they use a camera to look inside the uterus.
Exactly.
Okay, let me see if I can translate the statistical math here. The 4-millimeter rule is heavily relied upon because of its negative predictive value. I always picture this like a metal detector at an airport.
Oh, I like that. Go on.
The metal detector is hypersensitive, right? If you walk through and it beeps, it doesn't automatically mean you're carrying a weapon. It just means you might have keys in your pocket or a belt buckle.
Sure.
But, and this is the crucial part, if you walk through and it doesn't beep, security is almost 100% certain you do not have a weapon. It's designed to rule things out.
That is an excellent way to visualize it. In a woman with postmenopausal bleeding, a 4-millimeter cutoff has a 99.4% negative predictive value.
That's incredibly high.
It is. If she's bleeding, but her lining is 4 millimeters or thinner, the clinician can confidently say, the detector didn't beep. I am 99.4% sure this bleeding is not caused by cancer.
Which allows them to safely avoid a biopsy in a high-risk patient.
Precisely.
But here's where it gets really interesting, I think. The problem arises when you take that airport metal detector and set it up in the middle of a random grocery store, standing people who aren't even trying to get on a plane.
Exactly. The guidelines from the SOGC and the NHS explicitly warn that this 4-millimeter rule should never, ever be extrapolated to asymptomatic women.
Never.
Right. In a non-bleeding woman, an endometrial thickness of 8 to 11 millimeters is actually considered a completely normal physiological finding.
Okay, I need to pause here because this is the crux of the confusion.
Yeah.
You're telling me that a 5-millimeter thickness in a bleeding woman is a 5-alarm fire that requires surgery, but an 8-millimeter thickness in a non-bleeding woman is just a Tuesday.
Yeah, pretty much.
How can the tissue be almost twice as thick and yet be considered less dangerous?
It all comes down to understanding the actual mechanics of menopause. Menopause is not a light switch, it's a transition. I like to think of the uterine lining like a lawn in changing seasons. In the early years after menopause, what's called the onset of autumn, the ovaries are sputtering. They aren't producing high levels of estrogen consistently, but you still get sporadic, warm days.
Right, like an Indian summer.
Exactly. You get temporary spikes in estrogen. And those spikes cause the grafts of the uterine lining to grow a little bit, maybe reaching 8 to 11 millimeters. But because winter is setting in, it eventually stops, the estrogen drops, and the tissue just sits there, completely benign.
So a thicker lining isn't inherently a tumor, it's just a lawn that caught a warm breeze in November.
Precisely. And if we apply that 4 millimeter rule to asymptomatic women, the data suggests nearly 1% of the entire postmenopausal population would be flagged for unnecessary biopsies.
That is a massive number of women.
It is. We'd be actively searching for disease that is exceptionally rare in that group, and which almost always announces itself with bleeding anyway.
Right, so what does this all mean for the patient sitting on the table? Let's talk about the emotional and physical reality of what those unnecessary biopsies actually entail.
It's rough.
Because from a patient's perspective, if my doctor looks at a scan, sees a 9 millimeter thickening, and says, we're just going to leave it alone, my immediate thought is, you are ignoring a potential tumor. How does an ethical clinician manage that bedside conversation?
Well, this raises an important question about how we communicate risk. That is honestly the most challenging part of the job. It requires a fundamental reframing of informed consent.
How so?
An ethical clinician has to sit down with you and explain that they aren't ignoring a tumor, they're actively protecting you from the severe harm of the intervention itself.
Yeah.
Because a biopsy is not a benign procedure.
Right. The sources mention uterine perforation as a major risk. Let's unpack what that actually means mechanically to the body.
Sure. So an endometrial biopsy is often done blind in a clinic. The clinician inserts a thin tube called a pipelle through the cervix and into the uterus to scrape or suction out tissue.
Done blind, meaning they can't even see where the tube is going.
Right, they're going by feel.
Yeah.
And a postmenopausal uterus is often smaller, and the tissue can be very fragile. So a perforation happens when that instrument accidentally pushes straight through the muscular wall of the uterus, the myometrium, and into the abdominal cavity.
Oh, wow. Which means you could accidentally puncture a bowel or like a blood vessel.
Yes. It can turn a routine 5-minute clinic visit into an emergency surgery requiring general anesthesia and a hospital stay.
That's terrifying.
It is. So the ethical clinician has to look at the patient and say, I am not going to risk putting a hole in your uterus for a finding that has less than a 1 in 800 chance of being dangerous.
And the research backs up this watch and wait approach with a really staggering fact, right? Detecting these changes early in asymptomatic women provides zero prognostic advantage.
No whatsoever.
Like, if a woman has a thickened lining and she just waits, and then 6 months later she starts bleeding, she goes to the doctor then. Her survival rate is essentially identical to the woman who caught it incidentally 6 months prior, as long as she reports the bleeding promptly.
The rush to intervene simply does not save lives in this specific scenario. And we see this exact same philosophy, this idea that more data does not equal better care applied to diagnosing menopause itself.
Oh, you're talking about the FSH test, the follicle-stimulating hormone test.
I am, yeah. For women over 45, the clinical guidelines strictly discourage routine FSH testing to diagnose perimenopause or menopause.
Which feels super counterintuitive to most of us. I mean, we're conditioned to want the blood test to prove it. If I'm having hot flashes, I want the piece of paper that says, yes, your hormone levels are changing. Why wouldn't a doctor just order the test?
Because the biology of FSH and perimenopause fluctuates wildly from day to day. A single blood test is essentially a meaningless snapshot.
Really? Just completely meaningless.
Pretty much. If a woman over 45 presents with classic menopausal symptoms or a change in her menstrual cycle, the diagnosis is clinical. We know what's happening based on the symptoms.
So ordering the test is just redundant.
Worse than redundant. Ordering the FSH test wastes laboratory resources. It often causes unnecessary anxiety if the number looks weird on that particular Tuesday, and it actually delays the patient getting symptom management while they wait for the results.
It's the mechanic looking for a rattle again. If the car is driving fine, don't tear apart the engine. And if the car is obviously out of gas, you don't need a lab test to tell you why it stopped. Just put gas in it.
Exactly. It requires a massive shift in how we view healthcare. Doing nothing is often the most active, protective medical decision a doctor can make.
But doing nothing isn't a blanket rule, right? Like, if an ethical clinic is actively trying to avoid the harms of unnecessary biopsies, they still need a system to catch the actual outliers. They can't just throw all the scans in the trash.
Right, definitely not.
So how do they triage who actually needs an intervention?
It comes down to highly specific, individualized risk stratification. They aren't just looking at the single number on the radiologist's report. They combine specific ultrasound markers with the patient's unique biological history.
Okay, let's break down those biological markers. The guidelines note that for an asymptomatic woman, an endometrial thickness over 11 millimeters is the starting threshold for concern. But they're also looking for qualitative features on the scan, right? Things like increased vascularity.
Yes, and understanding the why behind increased vascularity is crucial. Tumors cannot grow beyond a few millimeters without their own blood supply.
They need nutrients to grow.
Right, so they physically hijack the body's vascular system, releasing chemical signals like VEGF, vascular endothelial growth factor, to force new blood vessels to grow directly into the tumor. This is called angiogenesis.
So the tumor is building its own plumbing system.
Basically, yeah.
Yeah.
And when a radiologist uses color Doppler on an ultrasound and sees a chaotic, dense web of blood flow in that thickened lining, that is a massive red flag.
They're essentially seeing the supply lines being built for the enemy.
That's a great way to put it.
The guidelines also mention looking for inhomogeneity. What does that look like?
So healthy tissue grows in an orderly, predictable architectural pattern. It looks smooth and uniform on a scan. Cancer cells are chaotic. They divide rapidly, they pile up on top of each other, and they create clumps of dense tissue mixed with areas of dead tissue.
So it's messy.
Very messy. That chaotic growth looks patchy or inhomogeneous on the ultrasound.
So an ethical clinic is looking for a combination. A thickness over 11 millimeters, plus the supply lines, plus the chaotic growth pattern. It's like a bouncer at a club. You don't throw out everyone in the building just because one person tripped. You look for specific troublemakers.
Exactly. And if we connect this to the bigger picture, they also factor in the patient themselves. The patient's physical risk factors completely alter the math.
Right.
A patient with severe obesity, chronic hypertension, or a history of late menopause has a completely different baseline risk.
Oh, where?
Or consider genetic factors like Lynch syndrome.
What's Lynch syndrome?
It's a genetic mutation that gives a patient a 40 to 60% lifetime risk of endometrial cancer. So for that patient, the conservative rules obviously do not apply.
Wow, okay. There's also this fascinating biological exception in the NHS guidelines for women who are taking tamoxifen for breast cancer. The drug apparently creates a really strange illusion on the ultrasound.
Tamoxifen is a brilliant example of why you have to treat the whole patient, not just the scan. So tamoxifen is a selective estrogen receptor modulator. In breast tissue, it acts as an antagonist. It blocks estrogen, which helps starve breast cancer cells.
But in the uterus, it acts differently.
Yes, it acts as a partial agonist. It
Yeah.
basically behaves like a weak estrogen.
And what does that do to the uterine tissue?
It primarily affects the stroma, which is the connective tissue supporting the lining. It causes what we call benign subepithelial stromal hypertrophy.
Meaning it puffs up the support beams.
Exactly. It causes the stroma to swell and develop these tiny cystic spaces. On an ultrasound, this looks terrifying. It looks thick, irregular, and highly suspicious for cancer.
But it's not.
Biologically, it is entirely benign. Because of this known mechanism, the guidelines state explicitly that asymptomatic women on tamoxifen should not receive routine transvaginal ultrasounds.
Because the scan is basically guaranteed to look abnormal.
Right, which will inevitably lead the doctor down a path of ordering a risky, completely unnecessary biopsy.
It's incredible how much context matters. And we see this same principle of watchful waiting applied to incidental ovarian cysts, too. If a woman gets a scan for abdominal pain and they find a simple fluid-filled cyst on her ovary that's like between 3 and 5 centimeters, they don't rush her to surgery.
No, they do not. The Royal College of Obstetricians and Gynecologists outlines a very clear conservative management pathway for that exact scenario. First, they check a CA-125 blood test.
Which is a tumor marker.
Right, it's a marker that can be elevated in ovarian cancer.
So if the blood test comes back normal, what happens next?
You wait. You simply repeat the ultrasound in 4 to 6 months. If the cyst hasn't grown and the CA-125 remains normal, the clinic can safely discharge the patient after a year.
Just let it be.
Yeah, the vast majority of these simple cysts are completely harmless and often resolve on their own. Even endometrial polyps, those small fleshy growths inside the uterus, they don't all require surgical removal. They're triaged based on the patient's age, the size of the polyp, and whether they're actually causing bleeding.
You know, it demands an incredible amount of discipline from the clinician. It has to be so much easier legally and emotionally for a doctor to just order a biopsy for every single anomaly and say, well, we checked, you're fine.
Oh, absolutely. It's much easier. It takes deep clinical expertise to synthesize these complex guidelines, look at a patient's specific biology, and confidently recommend doing absolutely nothing.
And it requires the patient to trust the science over their own fear, which is hard.
Very hard.
Which brings us to the core takeaway for you listening today. Asymptomatic postmenopausal tissue changes, whether it's a thickened lining or a small cyst, are incredibly common. They are often just the biological echoes of a body adapting to life after menopause.
Exactly.
Applying the rigid, aggressive diagnostic rules meant for bleeding patients to non-bleeding patients doesn't make you safer. It exposes you to painful, risky overtreatment. Ethical medicine protects you by relying on individualized risk factors and a deep understanding of cellular biology to decide when to intervene.
And understanding this difference between a high-risk symptom and a low-risk incidental finding is really the foundation of patient empowerment.
It's the armor you wear into the clinic. If you or a loved one ever receive a medical chart back with a flagged incidental finding, you now possess the vocabulary to advocate for yourself.
You can ask your doctor, what is the threshold for a non-bleeding patient?
Right. You can ask about conservative management. You can ask if the scan shows chaotic growth or just a temporarily thick lawn. You do not have to be rushed into a procedure out of misplaced panic.
The best defense against the cascade of medical overtreatment is an informed patient asking the right questions.
Absolutely. Now, before we wrap up this deep dive, there is one final, somewhat provocative thought I want to leave you with, based on the biology we've unpacked today. We've established that a temporarily thicker endometrium can be a normal consequence of fluctuating estrogen levels, right?
Right.
But our sources also explicitly highlight that obesity is a massive risk factor for endometrial cancer.
Yes, because of peripheral estrogen conversion.
Exactly. Fat tissue contains an enzyme called aromatase, which actively converts other hormones like androgens into estrogen. This means adipose tissue acts as a secondary estrogen factory, constantly dripping estrogen into the bloodstream and continuously stimulating the uterine lining long after the ovaries have shut down.
It creates a chronic, low-level proliferative state.
Right. So as global obesity rates continue to rise at an unprecedented pace, the baseline physiology of the average postmenopausal woman is fundamentally shifting. The amount of peripheral estrogen being produced globally is higher than it was 30 years ago.
That's a really interesting point.
It forces us to ask a difficult question about the future of these guidelines. How might the medical community eventually have to redefine what a normal baseline thickness is? Like, if the average estrogen level is permanently elevated across entirely different populations, will the 11 millimeter safety threshold still hold up in 20 years? Or will the lawns simply be thicker year-round?
Wow. It is a profound biological question, and it just shows that medical guidelines are never static. They are a moving target tracking human evolution.
They really are. So the next time your mechanic or your doctor tells you about a rattle you haven't noticed, take a deep breath. Ask for the context, ask about the biology, because sometimes the absolute best, most scientifically advanced medical intervention is deciding not to intervene at all.